أعزائي طلبة المرحلة الخامسة، السلام عليكم ورحمة الله وبركاته. Our subject today is about osteoarthritis. The learning objectives of this presentation are first to understand the pathophysiology of osteoarthritis and to define the main clinical features and radiological findings of osteoarthritis, and lastly, to define the principles of therapy of the disease. First, we should define osteoarthritis. It is a degenerative or wear and tear arthritis. It is the most common form of arthritis worldwide. It's strongly associated with aging. It is the major cause, represents the major cause of pain and disability in older people, characterized by the following. First, focal loss of cartilage, articular cartilage. Second, development of subchondral osteosclerosis with osteophyte formation at the margin of the joints. Also, it's associated with remodeling of the joint contour with enlargement of affected joints. Inflammation in this condition is not a prominent feature. This figure shows the component of normal joints and the joint affected by osteoarthritis. As we see here, there is thinning in the cartilage and with cartilage fragmentation with the development of osteophyte new bone formation. This is also the same as we see the cartilage which covers the bone. It is eroded and there is loss of cartilage, focal loss of cartilage with development of bone spurs or osteophyte. The meniscus also get erosions. Most common joints involved in osteoarthritis are the knees. Knees is the most common site for development of osteoarthritis, followed by hips, then proximal and distal interphalangeal joints of the hands. Regarding the spine, the two main parts of the spine that involve osteoarthritis are the cervical and lumbar vertebrae. This figure shows the most common joints affected by osteoarthritis. Few words about epidemiology. The prevalence of osteoarthritis rises progressively with age. Around 50% of all people develop new osteoarthritis and 1/4 hip osteoarthritis at some point during life. Lifetime risk of having a total hip or knee replacement secondary to osteoarthritis is about 11% in women and 8% in men. Osteoarthritis is more prevalent in women, except at the hip where men are equally affected. A few notes about pathophysiology. Osteoarthritis is a complex disorder. Actually, it is a joint failure, has both genetic and environmental components. The repetitive adverse loading of joints during occupation or competitive sports is an important predisposing factor. Some congenital anomalies of the joint, like slipped femoral epiphysis, can end with osteoarthritis. Obesity is a risk factor for osteoarthritis. Increased mechanical loading of the joints, cytokines released from adipose tissue. So we have two mechanisms. One, local mechanism due to increased load on the joint, and the second mechanism because of the cytokines which are released from adipose tissue in obese patients, which lead to degradation of the cartilage. Sex hormones may play a causal role. That's why the disease is more common in women. We have genetic factors which play a key role in the pathogenesis of osteoarthritis. The heritability of osteoarthritis ranges between about 43 at the knee to 60 and 65 at the hip and hand, respectively. Major alterations in cartilage structure are characteristic of osteoarthritis, as we said previously. The chondrocytes divide to produce nests of metabolically active cells. There will be increased degradation of the major structural components of cartilage, including aggregan and type 2 collagen. One of the characteristic features of osteoarthritis is the development of fissuring of the cartilage surface, what we call fibrillation. The subchondral bone also affected, not only the cartilage, the bone will be abnormal with osteosclerosis, increased deposition of calcium at the ends of the bone near joints with subchondral cyst formation. The fibrocartilage is produced at the joint margin, which undergo ossification and form osteophytes, which is a new bone formation. At the end, there's a process of bone remodeling and cartilage thinning, which develops slowly, will change the shape of the joint and increasing its surface area. Synovial hyperplasia and inflammation also occur, but to less extent than what happened in inflammatory disorders like rheumatoid arthritis. Clinical features. The main clinical feature of osteoarthritis is pain. Second is functional impairment, or due to functional restriction of the movement of the hands, knees, or hips, usually occur after the age of 45, but more often over the age of 60. The characteristic features of the pain is gradual in onset, over months, probably years. It varies in intensity over time. It's intermittent. The course of the disease, the pain is intermittent, mainly related to movement and weight bearing and relieved by rest. Only have a period of brief stiffness, mainly in the morning, for less than 15 minutes. It is very brief during the day, less than 5 minutes. We call it gelling phenomena after a period of rest. Usually only one or few joints are painful. Because of pain osteoarthritis, actually, as you know, the cartilage is denervated organ. So what are the causes of pain in osteoarthritis? There are many proposed mechanisms for this. First, increase pressure in subchondral bone. So the cause of pain is the bone, not the cartilage itself. Probably there is a trabecular microfractures inside the bone. Also the capsular distension, the capsules surround the joint, also its distension may cause pain. The low-grade inflammation of the synovium may cause pain. Also, the structures around the joint are inflamed in patients with osteoarthritis, like the bursae and the site of attachment of soft tissue to bone. All these, when inflamed, may cause pain. Other clinical features are restriction of the movement of the joint due to capsular thickening or blocking by osteophyte. There is a palpable and coarse crepitus due to rough articular surfaces. You can feel it on examination of the joint when we move the joint. There is also bone swelling, palpable around joint margins. At the advanced stage of the disease, there will be a deformity, joint line or periarticular tenderness also, muscle weakness and wasting, and some degree of inflammation. Now, we will talk about special entity of osteoarthritis called generalized nodal osteoarthritis. From the name generalized, it means that affects more than one joint, multiple joints, so it's polyarticular. Finger, mainly involved, finger joints, interphalangeal joints of the hand. There will be a nodes. When the nodes occur in the distal interphalangeal joints called Heberden's nodes, and the nodes developed in the proximal interphalangeal joints are Bouchard nodes. Also, the carpometacarpal joints are affected by this condition commonly. This special entity of osteoarthritis also it is more common in female. The peak age of onset is the middle age. The function is preserved in these patients in contrast to hand involvement or rheumatoid arthritis. There's a predisposition to other joints like the knee or hips. There's strong genetic predisposition. It is a familial condition actually. This figure shows the most commonly joints involved in patients with nodal osteoarthritis. This is Bouchard nodes and Heberden's nodes. The same. Also, this is the same. The joints of the foot also could be affected. So there's involvement of the big toe, this condition called hallux rigidus. The most common type or form of osteoarthritis is knee osteoarthritis. It targets the patellofemoral and medial tibiofemoral components of the joint. It may be isolated in the knee alone or occur as part of generalized nodal OA, as I said in the last slides. Most patients, particularly women, have bilateral and symmetrical involvement. The pain is usually occur in the anterior and the medial aspect of the knee and upper tibia. Also, we have patellofemoral pain is usually wards going up and down stairs or inclines. Sometimes there is posterior knee pain, suggests the presence of popliteal cyst or what's called Baker's cyst. Prolonged walking, rising from a chair, getting in or up of a car, bending to put on shoes and socks may be difficult. This is the popliteal cyst. It can be examined posteriorly in the popliteal fossa, the medial aspect. Deformities can occur in knee osteoarthritis. The most common is the varus deformity and or fixed flexion deformity. Joint line and or periarticular tenderness, secondary to answering bursitis and medial ligament enthesopathy. Also, there will be some sort of weakness and wasting of the quadriceps muscle and restriction, flexion, extension with coarse crepitus on palpation of the joint. Also, we can feel bone swelling around the joint line. This is the varus deformity of the knee, clinically and radiologically. What about hip osteoarthritis? Usually, it affects the superior aspect of the joint. Hip pain is usually maximal deep in the anterior groin with variable radiation to the buttock, anterolateral thigh, knee or shin. Also, there will be a functional difficulties as in knee osteoarthritis. Weakness and wasting of quadriceps muscles also occur in addition to gluteal muscles. Pain and restriction of internal rotation with the hip flexed during examination, the earliest and most sensitive sign of hip OA. Other movements will be restricted later on. Anterior groin tenderness, just lateral to the femoral artery pulsation. This is the osteoarthritis of the hip. Spine osteoarthritis, another common site which are involved by degenerative disease. Two parts of the spine are affected by osteoarthritis, the cervical spine and the lumbar spine. The osteoarthritis, or the degenerative process of the spine, we call it spondylosis. It can occur in isolation or as part of generalized osteoarthritis. The typical presentation is with pain localized to the low back region or the neck, can radiate to the arms or buttocks and legs due to nerve root compression by osteophyte. The pain is typically relieved by rest and worse on movement. On physical examination, the range of movement may be limited and loss of lumbar lordosis is typical. Straight leg raising test or femoral stretch test also may be positive. We should examine the patient for neurological deficit, which could occur due to spinal canal stenosis or due to nerve root compression. Early onset osteoarthritis, or what we call secondary osteoarthritis. It presents in people with age less than 45 years. In most cases, a single joint is affected and there is a clear history of previous trauma. So trauma is the most common cause of secondary osteoarthritis. Other causes should be considered, especially when the osteoarthritis develop in joints, and those joints who are not affected by primary OA. The causes can be classified according to the number of joints affected. Monoarticular, mainly due to trauma, or localized instability of the joint. Polyarticular or polyarticular, mainly the inflammatory causes, mainly juvenile idiopathic arthritis, metabolic or endocrine disorders like hemochromatosis, ochronosis, acromegaly, all could lead to early development of osteoarthritis. Late avascular necrosis, also the end sequelae of avascular necrosis is development of osteoarthritis, mainly of the hip. Charcot joints also end with osteoarthritis. What about investigations in osteoarthritis in general? The plain X-ray of the affected joint is diagnostic, and the features occur according to the severity of structural damage. We can assess the severity of structural damage with X-ray, plain X-ray. Non-weight bearing PA view of the pelvis are adequate for assessing hip OA, and the knee OA, we should have standing AP X-ray taken to assess tibiofemoral cartilage loss, and a flex skyline view to assess patellofemoral involvement. Spine OA can often be diagnosed on plain X-ray also. Typically shows evidence of disc space narrowing and osteophyte, lateral view and lateral view. MRI is indicated when there is signs of nerve root compression or spinal canal stenosis. This X-rays shows the main features of knee osteoarthritis. As we see here, there is a narrowing in the medial component of the knee joint. Also, there is a new bone formation, what's called osteophyte, and as we see also there is a subchondral sclerosis in the margin of the joint. This is the knee osteoarthritis, hip osteoarthritis. As we see here, the superior aspect of the hip joint is affected more, with narrowing of the joint space and sclerosis of the margin with osteophyte formation. Other investigations, routinely the biochemistry, hematology, antibodies, all are normal in patients with osteoarthritis. If we analyze the synovial fluid, it will be viscous with a low cell count. management. Actually, the management of osteoarthritis divided into three components: non-pharmacological, pharmacological, and surgery. The education and other general measures are important in osteoarthritis. We should explain to the patient the nature of the condition, the role of the relevant risk factors like obesity, heredity, trauma, and the fact that established structural changes are permanent, but that pain and function can improve, and this is an important point to be explained to the patient. The prognosis should be discussed. It is good for nodal hand OA as it not affect the function, more optimistic for knee than hip osteoarthritis. Exercise also has beneficial effect in OA, definitely, and it's the only approved mode of treatment of osteoarthritis which can make the prognosis better. It includes both strengthening and aerobic exercise. Quadriceps strengthening exercise are particularly beneficial in new osteoarthritis. Weight loss is important. Pacing of activities, use of walking stick for painful knee or hip OA, or provision of built-up shoes to equalize leg lengths can all improve symptoms. This is the straight leg raise in sitting position, in lying position, or the last one shows muscle stretching. This is the stick, which could be beneficial to decrease the weight bearing on affected joints. Pharmacological. The first line in treatment of osteoarthritis, first line medication is the paracetamol. Sometimes we are need for adding a topical non-steroidal anti-inflammatory drugs. Capsaicin also for knee and hand OA can also be helpful. Oral non-steroidals should be considered in patients who remain symptomatic. As we know, these drugs have many side effects, mainly gastrointestinal, in addition to cardiac and renal side effects. These drugs are significantly more effective than paracetamol and can be successfully combined with it. Opiates may occasionally be required in severe cases. For temporary benefit of moderate to severe pain, intra-articular injection of corticosteroids can be helpful, especially in patients with signs of inflammation like effusion of the joint. Local physical therapies, physical agents such as heat or cold therapies can sometimes give temporary relief like shortwave, ultrasound, and electrical nerve stimulations. Acupuncture and transcutaneous electrical nerve stimulation have also been shown to be effective in knee osteoarthritis. Antineuropathic drugs such as what's called neuromodulators such as amitriptyline, gabapentin, pregabalin also could be beneficial in some cases of osteoarthritis. What about chondroitin and glucosamine? It is used alone in combination for treatment of knee OA. There is evidence from randomized controlled trials that these agents can improve knee pain to a small extent, only 3 to 5% as compared with a placebo. So it is not a disease-modifying drug, not proved to be a disease-modifying drug in treatment of knee osteoarthritis. Hyaluronic acid injections in knee osteoarthritis, intra-articular injection of hyaluronic acid usually given as a course of weekly injections for 3 to 5 weeks may give modest pain relief for several months. Actually, it is beneficial in some patients with early OA or in advanced OA in patients who have contraindications to joint replacement, contraindications to surgery, like patients with heart failure or other conditions. There are some studies about the disease-modifying therapies. Actually, till now, no licensed drugs that can halt the progression of the disease. Glucosamine sulfate was shown in one study to slow the rate of radiological progression in knee OA. Recent randomized controlled trials suggest that strontium ralliate might also be effective in reducing the rate of progression of knee OA. But both of these medications are not approved as a disease-modifying drug. There is not enough study to prove this. Surgery, patients with osteoarthritis whose pain, stiffness, and reduced function impact, this is important, reduced function impact, significantly on their quality of life and are refractory to other treatments. This is the main indication for surgery, the functional impairment. Osteotomy can prolong the life of malaligned joints and relieve pain by reducing intraosseous pressure, but is performed infrequently. Total joint replacement surgery is by far the most common surgical procedure for patients with OA. Surgery should not be undertaken at an early stage during the development of osteoarthritis. It is important to consider it before functional limitation has become advanced, since this may compromise the surgical outcome. Only a small proportion of patients with osteoarthritis progress to the extent that total joint replacement is required. Still, osteoarthritis is the most frequent indication for a total joint replacement, whether knee or hip joints. Over 95% of joint replacements continue to function well into the second decade after surgery, and most provide lifelong pain-free function. This is the prosthetic joint. Thank you for listening. Wishing you all success.